Good day, chat. It's a bright one today. I hope that light doesn't interfere with things. You have to apologize. My office is also getting dirtier, but I've elected not to clean it. So at any rate, what case are we looking at today? So today we're going to do a case of a 30-year-old female who comes into clinic because she noticed a left breast lump just when she was taking a shower, and obviously she's concerned and she wants to know where we're going to go with things. So you as the resident have gone in and taken a history from her. She has no family history of breast cancer whatsoever, and we're going to get into what extra questions you would ask. And you've come back out to wonder if she's had a mammogram at this stage of game and where we should go with things. So here in Canada, who gets mammogram screening? So in general, if you take the general population, we start doing mammogram screening at 50 years of age or 10 years prior to your earliest relative. So if you've had a first-degree relative with breast cancer, that increases your risk by a factor of 2. If you've had 2 first-degree relatives, that increases your risk factor by a factor of 3. Now, there is also people we identify as high risk. So high risk individuals focus mainly around people who have a family history of breast cancer or ovarian cancer or prostate cancer or pancreatic cancer. That usually allows us to send people for genetic screening, or if you yourself have had a history of cancer, you can get genetic screening, or certain populations. Now, those populations are generally Ashkenazi Jews. We start talking about breast cancer in particular, French Canadians, which we obviously overlap a lot here in Canada. People of Dutch and Icelandic descent are another one that we actually look at. So if you actually qualify, you can get genetic testing done. And if you don't get it done. And the one you want to remember when you're looking at family history, it's that one that you have to sort of have some memory of what patients to send specifically. So if you have 3 first or second degree relatives on one side, generally you qualify. If you have two first or second degree relatives who've had breast or ovarian cancer before the age of 50, you generally qualify. Or if you've had one relative, usually less than 35, or one individual who's had both breast or ovary, or if it's a male relative, or it was really advanced cancer, those ones you'll qualify for in general for genetic screening. The pearl I would give you here is if you really just can't remember what those are, especially if you're early in your career, just send people, because especially in Canada, if they don't qualify, they won't qualify, but it'll tell you why, and then that'll start to become part of your memory, and you can realize who you're sending out for this. And why you want to send them in the first place is because if they are genetically positive, the main ones we see are BRCA1 and BRCA2, what we call BRCA1, BRCA2. And if you're actually positive for that disease, your risk of having breast cancer increases to about 50 to 85%. And how does that compare to the average population? And this is why breast cancer is such a terrible disease. But in general, if you look at American data, mostly Canadian too, and similar worldwide, about 1 in 8 women will develop breast cancer in their life. So about 12 or 13%, which is pretty terrible. But if you're BRCA1 or 2, that obviously accelerates by 4, 5, 6-fold. So getting back to this particular case, she's obviously at an age where she wouldn't have had any specific screening, and because she doesn't have a family history, that wouldn't have happened either. So what extra questions do you actually ask this patient? So certainly you want to ask if there's any puckering of the breast tissue. So puckering is actually the tissue is pulled inward, and that usually means that something's pulling on the ligament. Now that something is typically not malignant, but malignant issues are there as well. But it's, masses will do that to us, benign masses, surgeries that you've had, those type of things will do that to you. Or you can have dimpling of the skin, and that's different. Dimpling looks like what we call peau d'orange medically, and just this French name for what the skin of the orange looks like. So that's when the lymphatics are disrupted. You can also get issues with rashes. So rashes, we worry about Paget's disease, which is a subset we'll get into shortly when we talk about grade of cancer. Happens about 1% to 4% of cancers, and that's a rash, usually across the areola and nipple. So you certainly want to ask about that, but again, it's not very common. More common things you'll see is inversion of the actual nipple itself. Again, only about 5% of the time is inversion associated with actual cancer, so it's not typical, but you should be asking. And that's specifically unilateral. Contralateral inversion, 90% of that is congenital. Then you can get into nipple discharge, which you should ask me about as well. Again, very similar to inversion of the nipple. About 5% of the time that can be associated with cancer, but the majority will not. Bloody nipple discharge is a little bit different, but not by much. So that doesn't increase the incidence to a great extent. And then people tend to fixate on whether this is painful or not. Pain really isn't a good indicator of breast cancer. So if you take all individuals, only about 0.5 to 2% of the time is pain actually associated or ends up being breast cancer. If you take the entire cohort of breast cancers, about 15% of them will have pain associated with it. But as a screening potential, it's not that great. So in this particular case, we would now get into an issue once we've asked those questions about examining the patient. And essentially there's 3 cardinal positions we examine patients in, usually laying flat. You can have them laying on their side, and then you can have them examine when they're sitting up. Most of the time, most of us will examine when they're lying down, and if we feel anything, we may have them change position just to see if we can get a better feel for it. Or if we don't like the history and you don't feel anything when they're lying down, then certainly I'd encourage you to do all 3 cardinal positions. And you want to make sure that you're examining the entire breast. So the entire breast goes from the sternum all the way out to the axilla. So you should be doing a very big quadrant. And generally, I always follow the quadrants just like I would for a clock. And I sort of rotate in towards the nipple as I'm examining the breast. And then you want to feel the specifics of that specific mass. Now, things that would worry us, if I'm feeling something and it doesn't feel well circumscribed, which means it doesn't have good borders, then I'm a little bit nervous. Specifically, if it's tacked down to the underlying muscle, I won't like that. If it's painful for the patient when I'm doing it, I don't like that either. Or if I feel lymph glands, that would be something that's not seen as a positive either. So in this particular case, lymph glands were fine. This was a well-circumscribed mass, but it was definitely easily palpable. So therefore, we'd have to move this forward in terms of getting extra screening. So this patient was sent for an ultrasound. The ultrasound ended up showing there was definitely a mass that was there. And so now we had to send her for potential biopsy to see what this looked like. So what do you prepare your patients for in terms of biopsies? So there's essentially 5 different levels of biopsies. Now you can subdivide these because there's different types you can develop. As you increase these biopsies in terms of their intensity, they're less likely to have false negatives. And what is a false negative? It's when you actually get a test result that's negative, but that's actually incorrect. So when we're looking at biopsies, obviously, if I say my fist is the mass and I'm biopsying here and I'm actually missing it, then obviously I'm going to get a negative. Or if there's a pathological aspect for pathological reasoning, staining and whatever else, they just don't pick up on it, that can also result in a false negative. But usually it's more because we've actually missed the mass. So the simplest biopsy to do is called a fine needle aspiration biopsy. So essentially that one's just either localized easily between your fingers. They take a very small needle, they put some freezing over top of it, and then they'll do some multiple biopsies. Usually takes about 15 minutes, is minimally uncomfortable. But again, that would have the highest false negative rate. The next step up is a core biopsy. Now for a core biopsy, and you can prepare your patients, this usually takes about 15 minutes to about an hour. So this will be where they freeze the area up. They're going to use a larger needle and they're going to go in and out usually about 3 to 6 times to take a number of different biopsies. And that can either be guided. So if it's used by ultrasound, they call it ultrasound guided biopsies. If they use mammogram to actually guide it or mammography, then it's called a stereotactic biopsy. And that's the actual core biopsy. The one above this is called a vacuum-assisted breast biopsy or a minimally invasive breast biopsy, and this is also called a mammotome. And in that one, they actually use a probe, and I would tell patients ahead of time, in this one, you're not lying on your back, you're actually lying on your stomach, and your breasts are hanging underneath something that has an opening for them. And in this particular case, again, the mass is usually localized by ultrasound or by stereotactic means. And then they use a probe that they actually insert into that area. And then there's a vacuum pressure that vacuums area into it. And then that's cut. And they don't have to reintroduce the probe. So even though they can adjust it and take like 8 to 10 biopsies and it's a bigger area, it's not something that actually requires reinsertion. So it's actually only one insertion. So in all 3 of these first ones, this is essentially non-scarring. It's all local anesthesia, even though all of them are local anesthesia. And so this is pretty straightforward. The last 2 are a little bit more invasive. And this is an incisional biopsy and an excisional biopsy. And this is going to involve a scalpel. So usually in these cases, you're actually identifying the area. So either by seeding, so they put something about the size of a sesame seed to localize the area that they found by, again, ultrasound or stereotactically. And in incisional biopsies, you'll make an incision with the scalpel, you'll go in and you'll excise out that seed and the tissues right around it. And then in an excisional biopsy, it's the same type of thing, but now you're taking the entire area out. And the decision as to what you're going to do with those all depends on the size of the mass, the patient, because obviously, the bigger the biopsy, the more likelihood you have for bleeding, for post-op retraction, for asymmetry, for scarring, all that type of stuff. And this is where you certainly want to be talking to the patient because they're going to have input here. So, and don't be afraid to offer your opinion. I always This is something I try to encourage my residents as much as possible. And I think in the States, because it's a little bit more litigious, they're even more nervous about that. But if patients ask you what you would do, like, don't be afraid to give your opinion. By the same token, don't be insulted if they don't take your advice. But if they ask your opinion, then give your opinion. Tell them what you would most likely do in this scenario and the pros and cons. And where I say they factor into this, personality is huge here. Like, sometimes patients want to have as much done as possible because they just have to have whatever it is there that's out, even if it's benign. So you have to actually be considering that as you get to the bottom of what you're going to do and how you're going to approach this. So in this particular case, a biopsy was done and then this was sent off. And this is going to go to the pathology, and then what you're going to get back is an actual diagnosis, a tissue diagnosis. And we refer to this as the grade of whatever's going to happen if it's actually cancerous. So if we're lucky, we're going to get back something entirely benign, something that's not cancerous. And then we just have to always consider whether this could be a false negative. And if that's the case, we're going to re-examine this or do a more detailed assessment of what's going on from the standpoint of screening or whatever else. But if it comes back as cancerous, as regrettably this particular case did, now we have to move forward in a different direction. So first and foremost, we're just going to get the actual grade of the actual cancer. So that's just actually the tissue type. And that can be a couple of different things. So what we hope for most commonly is that we get something that's actually in situ. So ductal carcinoma in situ or lobular carcinoma in situ. In situ just means that it's still within the ductal system. It hasn't spread, or what we essentially refer to as non-invasive cancers. These are not life-threatening. These are easily manageable, and these would be our best case scenarios. Beyond those, though, we start to get into invasive cancers. So the most common is invasive ductal cancer or invasive ductal carcinoma. That represents about 80% of cancers. And this has about 4 subtypes. I know tubular is one of them. I always have to look those up. I can't remember what they are off the top of my head. But those are essentially what you'll be given from the standpoint of a specific cell type. There's also invasive lobular carcinoma. That represents about 10 to 15% of cancers. Again, there's about 5 subtypes for this one. And then you get into Paget's disease, which is actually what I talked about before, about 1 to 4% of the time, and that's more of a rash you'll see associated with it. And there's also infiltrating cancer, carcinoma. That's about 1 to 5% of cancers. And then there's also something called Phyllodes tumors. Phyllodes tumors, 75% of these are actually benign, 25% are actually cancerous. So hers came back as invasive ductal carcinoma, if I remember properly. So now that we have this diagnosis, what do we tell the patient now? And what I would tell you is, as soon as I get an actual diagnosis of cancer, I actually give all of my cancer patients my phone number. Now, this is something, again, you may choose to do or not do, and I don't judge you one way or not for it. But especially in Canada, navigating the system is actually hard. The Canadian medical system is a little bit broken in a lot of different ways. So getting tests done in appropriate fashion, getting the specialists involved, that can take time. And on top of which, patients are just going to have a ton of questions. And I don't want them to have to come in and take the time. If they can message me and I can answer it for them, then that would be preferable. And similarly, if I order tests, I have no idea if those have come back or not, or how quickly they're pending. So I certainly want them to be involved in that process and let me know, what's going on, what can happen. We also have available to us a branch of the actual medical system that actually works these up quicker, and that's an agency that helps us as well, but that system's not perfect either. So we sometimes have to have a balance with respect to what we're actually doing. So the next stages of what has to happen is we actually have to wait for histochemical staining on the actual breast biopsy to find out whether this is actually hormone positive or HER2 receptor positive or not. We'll come back to that in a second. And we also have to determine the stage of the cancer, how far this is actually spread. And for that to happen, you got to get extra testing done. So where does breast cancer spread to? And breast cancer spreads predominantly to the bone, to the liver, and to the lung, which are the structures around that. So because of that, you essentially want to get a CAT scan of the chest, the abdomen, and the pelvis, and you want to get a bone scan done. So you would order those right away. And like I said to you, you would then want the patient to let you know whether you're getting them right away. In a perfect system, you get the same day. And this is where I would tell you elements of the American system are certainly superior to the Canadian one. Where the American system lags is that if you don't have coverage, you're really in trouble and you could lose your house and all that stuff, which is terrible. But higher end coverage in the American system is really quite slick, and you get all of this done very quickly, which is how it should happen. So you'll order those tests and then you have to wait for them. And now that you have a pathological diagnosis, you can also consult the surgical group to get them involved as well, and potentially the cancer clinic. So the surgical group will deal with excising this specific area, whereas the cancer group will deal with radiation, chemotherapy, and hormonal therapy. So both groups will have to be involved. So when you send those out, you then were waiting for this, and then the next thing that's going to come in is the actual hormone testing. And that essentially looks for 3 different things. So it looks for receptors that are actually on these cancerous cells. And ideally, you want these to be positive. So thankfully, about 2/3 or about 70% of cancers will actually be hormone receptor positive. And what that means is that the surface of the actual cancer has estrogen or progesterone receptors on it. And while that's a good thing, is because if they're positive, you can actually treat those. And if you treat them with these medications that are available, you could potentially shrink tumors, and which is obviously going to have a positive impact, which people who don't have those don't have access to. So your worst case scenarios will be what we call triple negative disease. So it's estrogen receptor negative, it's progesterone receptor negative, and it's HER2 receptor gene negative as well. So if you look at those that are positive, how many are estrogen receptor positive? About 80%. About 65% will be estrogen and progesterone, and only 2% will just be progesterone only. But when those are actually positive, you can treat them with 3 different types of medications. So there's what we call aromatase inhibitors. So aromatase inhibitors inhibit the enzyme aromatase, which converts androgens into actual estrogen. Now there's 5 different types of androgens, the most prominent being testosterone. But then there's also DHEA, there's DHEAS, there's androstenedione, and there's androstenediol. So those are the 5, and that conversion to estrogen is what you want to avoid. Now the problem with those is it doesn't inhibit the ovary from producing estrogen, so it's only really useful in postmenopausal women. The next level you can use is what we call a selective estrogen receptor modulator. In Canada, the most common we have is called raloxifene, or the trade name is Avista. And that essentially blocks the estrogen receptor. So it can't be bound, and by not binding it, it sort of deregulates the cell, and then it doesn't develop, doesn't replicate, those type of things. Now there's also another class, which is the receptor down regulators. The problem with those ones, they also bind, but they also decrease the number of estrogen receptors on the actual cancer cell, which we don't want. So those aren't used very commonly. And the one thing I should mention, you can be estrogen receptor positive, and then with time you become negative, and you have to be aware of that. And very similar, the opposite can happen. So if people have recurrences, you want to make sure you do new biopsies, because it may be a different scenario and they may have new treatment options available to them based on that specific issue. And the other thing we look for is HER2 receptor gene, and whether they're positive or negative. And that's the human epidermal growth factor receptor gene. And essentially what happens in those cases is if that's upregulated, then again, you produce too much of that specific protein, and that increases growth through the actual cancer cell, which will lead to larger tumor size and more spread. And if you're actually positive, there's actually medications, Herceptin being the most common, but there's a whole bunch of other ones that actually target that receptor and again, downregulate it. So this you actually want to know because it gives your patient options. Now, if you're completely negative, do you have other treatment options? And this is where those other referrals come in, because you still have access to radiation, to chemotherapy, and to surgical options specifically. Now, I'm not going to get into that with this specific video because it otherwise becomes very long, but we'll have another one that looks at the treatment specifically. And the other things you always want to consider, and this has been an area where I've been disappointed with the overall system, there's also the whole aspect of homeopathic treatments and herbal treatments and all those type of things that we really don't consider to a great extent. And the reality is no one really does a lot of studies in those because there's not a lot of money in it. So you're not going to see Pfizer or any of the other big names come forward and do that. And that's no knock against Pfizer specifically, because they're in the practice of making money. But I wish with our cancer clinics, we had a subdivision that would look at all those naturopathic treatments and could guide patients a little bit more. If you're in this to any great degree, you'll have to acquire some degree of knowledge in those areas. And I certainly have looked into those type of things, whether you're looking at green tea or dandelion or various other treatments. And you always want to look at it from 2 perspectives. Is it detrimental to the patient? And I include with that financial detriment, and does it actually work? So you may find treatments that have very minimal data that shows it's positive, but because there's virtually no negatives, there's no loss in actually doing it. So you want to be encouraging that as much as possible. And if the patient is certainly motivated in that direction, then that becomes a viable option for us. The other thing I'll mention before we close this specific case is, You certainly want to consider too cases if you do have stage 4 disease. If you have groups within your area that sign off on the patient are essentially saying there's nothing we can do further, you do want to look towards teaching facilities where they're maybe doing phase 2 and phase 3 trials, and just making sure that your patient's aware that those are happening. Here in Canada, Princess Margaret, which is in Toronto, is our hospital, does a lot of phase 2 and phase 3 trials. In the United States, there's the National Institute of Health, the NIH that actually provides that. And if you qualify for those studies, there generally is not a cost to the patient. So even as a Canadian, you can actually, if you qualify for those programs, patients will have options. And essentially those are treatments that are coming to the forefront. So they're not actually standards of care, but whereas the local cancer groups may not realize there's a treatment coming, these areas will. And you certainly want to open that up to patients, especially if you've been giving a more aggressive diagnosis, that's stage 4 and they don't think they can do anything for them. There might be options there that you want to be aware of, so you can actually steer your patient in that direction. All right, so I'm going to just end that case here, just because that's where we take things to in general. There certainly is arguments about what type of chemotherapeutics, what type of specific surgeries, and how that surgery unfolds, and we'll touch on that in other cases. But this is the stuff that we want to know as a primary care physician to help our patients understand what that biopsy is going to look like, why we want to know if they're actually hormone receptor positive or not, and what treatments might be coming for them. And if I could leave you with a final note on this topic, it would essentially be just this. If you're primary care involved in these cases or nurse practitioners, never forget how scary this is for patients. Especially that particular patient, this 30-year-old beautiful young lady she's so young looking, she looks 16. Like, this has rocked her world and she's still ongoing with these treatments. But this is the case with anybody at any age. Like, cancer is extremely scary. And we can sometimes lose focus of that, when we're in this on a day in, day out basis. And this is particularly sensitive to me because 4 years ago, I lost my mom to this terrible disease. And she was arguably, the world's best nurse, certainly a fantastic mom. And she had the worst spread of breast cancer I'd ever seen. It was all over in her meninges, in her brain. It was absolutely everywhere. So this is just something you never want to take for granted. And when you're breaking this news to specific patients, you always got to remember that they're thinking about those worst case scenarios. So always be sensitive to that. Deliver this information as best you can. Be as informed as you can, so you give them that resource. And the more you can know about this topic, the better you'll do with your patients, and hopefully better outcomes they'll actually have.